So what I want to cover with you today is, first of all, where are we at? What are our treatment goals? Then what's the efficacy of antipsychotics? What about additional domains? Usually we focus on total symptoms, positive symptoms, maybe a little bit on negative. So what about depression and cognition and schizophrenia, adverse effects and conclusions? So let's go to treatment goals. This is from a paper we published maybe now 2.5 years ago or so, where we put together the numbers in patients with schizophrenia who were either chronic in black or first episode in red, and looked at, well, what's the outcome when we pool data or go to meta-analyses? So when patients come to us, they're often exacerbated, and what we want is a reduction in symptom. That's called response. And you may be as acutely and painfully aware as I am that 6 decades, 60 years, after the serendipitous discovery of chlorpromazine, we're still talking dopamine for psychosis. There is not yet a medication that has a second system that is dialed in order to reliably treat psychosis. From primary data in animals and other preclinical studies, we know that most likely glutamate is involved, most likely GABA, the cholinergic system, but we haven't been successful modulating those systems, at least with a pill. Now, that's one thing. On the other end, though, we have been able to modulate the modulation of dopamine. Yeah, so we came from the first generation drugs that had a lot of either dirty pharmacology or were too clean and hit the dopamine receptor too much. And now we can modulate dopamine tone in a way that is milder, and we don't have as many neuromotor side effects. But then obviously came all the cardiometabolic side effects, and even those have now with newer and newer agents been diminished. So what's the outcome? In chronic patients, 1 out of 5 to 2 out of 3 respond. And as you know, first episode patients, the most vulnerable, the ones that have arguably the most to lose and the most to gain, respond far better, 40 to 90%. But even response is a relative outcome. People might be better, but you don't know whether they're well. And most of you said quality of life. Well, a 20% reduction over 100 on a PANSS score gives you an 80. That's a response in many studies. But with 80, you can go right into the next acute study. So in order to know whether somebody's not better but well, we need an absolute outcome, and that's called remission. Since 2005, defined as 6 months of no more than mild positive and mild negative symptoms. 4 positive, 4 negative. And that's where we already run into trouble. The symptomatic stability for 6 months or more, less than half of our chronic patients will achieve that. That's not good. Let's look at first episode patients. They do better, but the lower bound is getting to become a little problematic. But even remission is a symptom-based approach to people, and I hope you and I went into mental health to treat people and not symptoms. And in order to define symptoms, we need functionality. And so in prior studies, this was either a GAF score to define recovery, a GAF score of 65 or higher. But in modern times, it's 1 or 2 years of symptom stability, no more than mild symptoms. That's the symptomatic recovery, but then the functional recovery is added to have adequate self-care, food, shelter, hygiene, at least one psychosocial contact outside of the family. I don't know, I get that always. And then also having to do something meaningful with your life. Getting up in the morning, 2 days, even unpaid school or work. And that's where we still fail our patients. In the Yaskulain meta-analysis that this is taken from, 50 years of research showed 13.5% of people with schizophrenia have at least 1 or 2 years of this symptomatic and functional recovery. That's really bad. But what's even worse is we have this critical period of treating people with first episode who respond and remit better, but they don't integrate better, they don't have the recovery we want. So the question is, what's the block on the road to recovery? Where do we fail? What's going on? What do we do wrong? Where can't we help our patients enough? So the authors of the Yaskulain meta-analysis asked a slightly different but related question and said, okay, if the recovery is so low, might it be because we can't get them functional, but we can at least treat the symptoms? So they looked at 1 or 2 years of symptom recovery, no more than mild symptoms, without the functionality, and hoped that this would give us higher rates versus, okay, we want all the functionality. actually it did not matter. Both rates were extremely low. What does that tell us? That tells us something very important, that what's on the road to recovery, the block, is what you and I fight with every day with our patients. And that is this animal here. People are not stable for long enough so that you can rehabilitate them to reintegrate them. They often stop the medication, they break through, and they have relapse after relapse after relapse. And that is what happens when people stop medication. This is taken from the Leucht meta-analysis, I'll show you later, where patients were stable on an antipsychotic and then were randomly either moved to placebo, and this is the placebo arm data, or stay on treatment. So when people stop their treatment, within 3 months, 1 out of 3 people relapses or worsens significantly to be removed. Within 6 months, it's 50%. Within a year, it's 2 out of 3. And within 3 years, it is 80%. And the lower numbers here are from a study we did at Hillside Hospital, where, again, patients with a lot of psychosocial support, $5 million for 137 patients, and a wonderful social worker wrote a book about schizophrenia with the young family members and the patients, and still, after 5 years, 82% one relapse, 78% a second, and 84% a third. And what was the number one factor for relapse? It was not a certain imaging marker which we looked at, neurocognition, side effects, what have you. It was a very simple element. Even your grandma could have told you, honey, if you don't take your meds, you'll get sick again. So not being on medication was a 500% increased risk. And that was not only patients having lack of illness inside and being non-adherent. These are first episode patients. They're doing well, and then clinicians after a year or two, this was done in the 90s, said, well, maybe we should stop. And then boom, they relapsed. Now, the problem with relapse is, A, we're interrupting the road to recovery. We are not able to get people reintegrated. People after each relapse have self-stigma, learn that they are chronically ill, but there's not only a psychosocial cost, there's a biological cost. Because this animal here gets larger with each relapse. We know that after each relapse, about 1 in 7 people will not respond as well anymore to the same medication that they did respond to before. Remember the kindling hypothesis that we had with antiepileptics? The brain is a learning machine. Whether you do skiing, learning a language, navigating in a new city, being depressed, anxious, or psychotic, our brain gets better at it. So we need to really curb the relapses in order to integrate people and diminish the development of resistance, which in first episode samples is about 5 to 10%, but then relapse after relapse is 30 to 40%. Since treatment discontinuation is a biggie, and since side effects are a big factor for treatment discontinuation, we should treat patients from the beginning with the lowest risk medications that they can have the best psychiatric and physical outcome. And you will see that certain side effects actually diminish particularly quality of life, and then why would people continue the treatment? So, psychotic disorder patients live 20 to 25 years shorter. That is a really big problem. Jackie Curtis, who's here in the audience, is one of the founders of the HEAL, the Healthy Active Life initiative, which originated in Australia because you're outdoorsy people and you love to be healthy, and Bondi Beach, well, why wouldn't you think of health? But that's important, and I think we now know that we have to get people healthy both physically and mentally. And we can, yes we can, either with also doing exercise treatment for some people who accept it, but in other ways at least giving them medications that are healthier. Because people in Australia, these are my Australian data that I'm showing to you so that you feel grounded, people with psychosis in Australia have a lot of cardiometabolic burden. Look at that. It's 82% have abnormal waist circumference, which is a marker of abdominal adiposity, really bad fat that increases oxidative stress, inflammation, and most likely via that pathway also then makes people worse in terms of psychiatric outcomes. I'll show you some data to that later. Half of them have poor lipid, hypertension, and triglyceride levels, and about between a quarter and a third have plasma glucose problems. If you look at obesity, half are obese, a third almost are overweight, and over 90% have none or very poor physical exercise. So that's the backdrop of the people who we treat. So basically, what does the Australian guideline say? You need to monitor and you need to improve outcomes in order to decrease cardiovascular risk. But I would add data accumulating to improve psychiatric outcomes too. It's not the body and the brain are connected through the neck. It's not just you have a heart issue. We know that inflammation is bad for your brain too.